So stress is something that affects us all from time to time, and we react to it in ways that are mediated mainly by the endocrine and sympathetic nervous systems. Stress is caused by any situation that upsets homeostasis and threatens one's physical or emotional well-being. Injury, surgery, infection, intense exercise, pain, grief, depression, and anger can all cause us stress. And I think this is a particularly interesting topic because when it comes to things like pain, grief, depression, and anger, these are all emotions that we can modulate. We have a choice about how much we let grief affect us and how much depression affects us. And we do have the capacity to modulate our response to fear. Once you understand this general adaptation syndrome stuff, you might be more interested in modulating how you respond to certain situations that arise in your life. General adaptation syndrome is the consistent way that the body reacts to stress. Typically, it involves elevated levels of epinephrine and glucocorticoids, especially cortisol. It occurs in 3 stages. There's the alarm reaction stage, there's a stage of resistance, and then a stage of exhaustion. In the alarm reaction, this is our initial response. It's our initial fight or flight reaction. Fight or flight in response to a real event or even a perceived event has the same response. It's mediated by norepinephrine from the sympathetic nervous system and epinephrine from the adrenal medulla. It prepares the body for fight or flight. Stored glycogen is consumed. We'll see an increase in aldosterone and angiotensin levels, which helps raise the blood pressure. And aldosterone will also promote sodium and water conservation, all the things that we need in the event of fight or flight. However, if this goes on for an extended period of time, we already looked at the interactions between the adrenal medulla and the adrenal cortex. So during the stage of resistance, we'll see that cortisol is dominant. After we've had all of this epinephrine released from the medulla, some of the connections go into the cortex and cause release of cortisol. After a few hours, our glycogen reserves are gone, but the brain still needs glucose. So cortisol is involved in providing alternate fuels for metabolism. The hypothalamus will secrete corticotropin-releasing hormone. The pituitary will secrete an increase in adrenocorticotropic hormone, and this stimulates the adrenal cortex further to secrete more cortisol and other glucocorticoids to help us deal with the stress. And the cortisol promotes breakdown of fat and protein into glycerol and fatty acids and amino acids for gluconeogenesis, that is, forming glucose so that we can keep glucose in our blood and keep our brain alive. Thus, cortisol has a glucose-sparing effect. That is, it uses other fuels for metabolism in order to keep as much glucose in the blood as possible to fuel the brain. This glucose-sparing effect will also have the result, because we're breaking down proteins, it's inhibiting protein synthesis and leaving free amino acids so that we can produce more fuel for metabolism. There are adverse effects of having excessive cortisol. As we've already explored, cortisol can be used in suppressing immune function, and so it does indeed depress our whole immune function. So that causes us to become ill, which creates more stress. So we almost have a positive feedback system going on. It'll increase our susceptibility to infection and thus ulcers. We'll see that lymphoid tissues start to atrophy and our antibody levels drop. Wounds will start to heal poorly, and so will bruising. When the stress continues for several months and our fat reserves are gone, we end up in the stage of exhaustion because homeostasis is totally overwhelmed. And once one system goes out of homeostasis, other systems will follow. The stage of exhaustion is marked by rapid decline and often death if nothing is done to rectify the situation. We'll see that the proteins break down and muscles start to waste away, loss of glucose homeostasis because the adrenal cortex stops producing glucocorticoids. We'll see downregulation of the receptors, and so cells are much less sensitive to the glucocorticoids. Aldosterone will promote water retention and thus hypertension and edema in the tissues. Will conserve sodium, which hastens the elimination of potassium and hydrogen ions, and that can lead to hypokalemia as well as alkalosis. Usually, death will result from the heart and kidney infection or overwhelming infection in general throughout the body. So, going back a couple of slides to think about all the things that could cause you stress. We all experience stress, right? But how do we manage our stress? What do we do to take care of ourselves in the events of stress? Do we allow our mind to go wild and become more and more angry or more and more depressed at a certain situation? What causes us grief? Could it be real things? Like, undoubtedly, if you lose a parent, it's going to cause grief, but how much do you let that get into your body rather than find the positive out of the situation? So it's really, really important for us to manage our stress properly so we don't move into this stage of resistance. The stage of resistance can go on for a long, long, long time. It can be a slow downhill until we get into the stage of exhaustion, and then it's a quick downhill. Neurotransmitters and hormones are not the only chemical messengers in the body. We'll briefly consider here the paracrine messengers. These are the chemical signals that are released by cells into the tissue fluid. They don't travel to their targets by the way of blood, but diffuse from their source to nearby cells in the same tissue. So unlike the neurotransmitters, paracrines are not produced in neurons, and unlike hormones, they're not transported in the blood. A signal chemical can either act as a hormone, a paracrine, or even a neurotransmitter, depending on the location that it's secreted. Histamine is released by mast cells that lie alongside the blood vessels in a connective tissue. It diffuses to the smooth muscle of the blood vessel, relaxing it and allowing vasodilation. Nitric oxide, another paracrine vasodilator, is released by the endothelial cells of the blood vessel itself. In the pancreas, somatostatin acts as a paracrine signal when it's released by the delta cells and diffuses to the alpha and beta cells in the same islet. And as we just highlighted, catecholamines diffuse from the adrenal medulla to the adrenal cortex without ever entering the blood supply, so they are paracrine secretions. Eicosanoids are a family of paracrine secretions that are derived from a fatty acid called arachidonic acid. The enzyme lipoxygenase converts arachidonic acid into leukotrienes. And cyclooxygenase converts arachidonic acid into 3 other types of eicosanoids. The first of these is prostacyclin, which is involved in inhibiting blood clotting and vasoconstriction. The thromboxanes are produced by blood platelets after injury. It overrides prostacyclin and stimulates vasoconstriction and clotting. The prostaglandins include PGE, which relaxes smooth muscle in the bladder, intestines, bronchioles, uterus, and stimulates the contraction of blood vessels. And PGF has the opposite effects. Now, this is mainly interesting because of some classes of anti-inflammatory drugs. Cortisol and corticosterone can be used as anti-inflammatories, and they will decrease the inflammatory response. However, both of these are steroids, so they're called steroidal anti-inflammatory drugs. They inhibit the inflammation by blocking the release of arachidonic acid from the plasma membrane and inhibiting the synthesis of the eicosanoids. The disadvantage of cortisol is that we can't use it for a long period of time. It can produce the symptoms of Cushing's syndrome, which result from overexposure to cortisol. We'll take a look at that shortly. There's another class of anti-inflammatory drugs, like aspirin, ibuprofen, and Celebrex. These are non-steroidal anti-inflammatory drugs, and so they are, in theory, better for us to use, NSAIDs. They're a class of what we call COX inhibitors. They're COX inhibitors because they block the enzyme cyclooxygenase. It doesn't affect lipoxygenase, so we still get plenty of leukotrienes. But we do prevent the inflammatory responses that are produced by prostacyclin, thromboxanes, and prostaglandins. Because of this, they can be useful in the treatment of fever and thrombosis, as well as any pain that comes about in response to inflammation. Naturally, there are a number of endocrine disorders that result from variations in hormone concentration as well as target cell sensitivity. These can have noticeable effects on the body. They fall into two general classes: hyposecretion, where there's inadequate hormone release, or hypersecretion, in which we'll see excessive hormone release. In hyposecretion, there could be a tumor or a lesion that destroys the gland and interferes with its ability to receive signals from another gland. Head trauma, for example, can affect the pituitary gland's ability to secrete ADH, which can cause chronic polyuria or diabetes insipidus. Autoantibodies fail to distinguish between the gland and foreign matter and can destroy the gland, and thus we see lower secretions of the hormones. In hypersecretion, we can also have tumors or autoimmune disorder. For example, pheochromocytoma, or the tumor of the adrenal medulla, secretes excessive epinephrine and norepinephrine. Or a toxic goiter, like we might see in Graves' disease. There will be antibodies that mimic the effect of TSH on the thyroid, causing thyroid hypersecretion of its hormones, and thus elevated metabolic rate. In the following slides, I'll brush over a few of these disorders. We're not going to go into them in too much detail, but just to be aware of some of the different possibilities. If we see pituitary disorders, we might see growth hormone. Acromegaly is the thickening of bones and soft tissues in adults, especially in the hands, feet, and face. Now, I'd introduced the idea that some people have found growth hormone to be the elixir of young life. However, too much growth hormone can result in overgrowth of these bones and soft tissues. If we see a hypersecretion during childhood or adolescence, we might see gigantism or dwarfism in the case of hyposecretion. It's pretty rare to see dwarfism because of pituitary hypersecretion of growth hormone, because we now have genetically engineered growth hormone that's produced by bacteria that's readily available once we see this hyposecretion. Thyroid gland can have a number of different disorders. Congenital hypothyroidism, where we see decreased thyroid hormones. Myxedema with decreased thyroid hormones. A goiter is a pathological enlargement of the thyroid gland. This is an extreme case over here. An endemic one is due to dietary iodine deficiency, and so we can't even produce thyroid hormone, and thus there's no feedback of thyroid hormone to decrease the TSH secretion. And so we see so much TSH secretion that hypertrophy results in the thyroid gland. It's these endemic goiters that brought us to put iodine in our salt. You've probably noticed that most salt that you buy in the grocery store is iodized salt. It changes the flavor a tiny bit, but not entirely. Chefs will generally use sea salt or kosher salt in order to avoid some of this change in flavor. Now, toxic goiters are a whole nother story. It involves autoantibodies mimicking the effect of TSH, so we get hypersecretion of TSH. which continues to stimulate the thyroid gland, and thus we produce a huge amount of thyroid hormones, an elevated metabolic rate. There are some parathyroid disorders, both hypo and hyper. In the case of hyperparathyroidism, there's excess PTH, which causes the bones to become soft and fragile and often quite deformed. Calcium and phosphate levels in the blood will increase, and this promotes the formation of kidney stones or renal calculi. Some adrenal disorders include Cushing's syndrome, which results from excess cortisol, or androgenital syndrome, which results from hypersecretion of adrenal androgens. We'll see enlargement of the sexual organs in children and early onset of puberty. Newborn girls could exhibit masculinized genitalia, and women may have increased body hair, deeper voice, and even beard growth. Diabetes mellitus is the most prevalent metabolic disease in the world. It's a disruption of metabolism due to hyposecretion or the inaction of insulin. The symptoms of it are polyuria, which is excess urine output, and polydipsia, which is intense thirst, a result of that, and polyphagia, because we're not having enough glucose packed away in the cells, and so we're hungry all the time. We see elevated blood glucose in the case of diabetes mellitus, and also glucose in the urine, because the kidneys cannot pull glucose out fast enough to keep up with the excess urine output. And thus we'll see that we'll have ketones in the urine also. You see, the glucose transporters can only work so hard to reabsorb this excess glucose, and so we find it in the urine. Some of the first tests for diabetes actually involved tasting of the urine to see if it was sweet. There are two types of diabetes, type 1 and type 2. Type 1 only accounts for about 5 to 10% of the cases in the US. And it's thought to result from having an autoimmune response where our antibodies attack and destroy the pancreatic beta cells. Thus, a diabetic cannot produce any insulin of his or her own. And so insulin injections are always used to treat this type of diabetes. Type 2 is non-insulin dependent diabetes mellitus, and this is 90 to 95% of diabetics in the United States. The problem here is insulin resistance. It's failure of the target cells to respond to insulin. So there's a lot of insulin present, so it doesn't make much sense to treat this condition with insulin. The risk factors for diabetes type 2 is being over 40 and obese. We see a higher prevalence of it in Native Americans and Hispanic and Asian populations. Doesn't mean that it doesn't show up anywhere else. It's just more prevalent in those populations. Mostly, diabetes mellitus type 2 can be treated with weight loss and exercise. The loss of muscle mass that we see with lack of exercise causes difficulty in the regulation of glycemia or glucose in the blood. And adipose signals interfere with glucose uptake of most cells. The majority of people with type 2 diabetes are overweight. That doesn't mean that all people with type 2 diabetes are overweight, but one of the explanations for the resistance to insulin is that our storage cells, like fat cells, have become so distorted, the receptors for insulin have changed shape slightly, and so insulin no longer works as effectively in order to pack the excess glucose away. Now your text goes into more details on each of these disorders, so go ahead and take a read through each of those sections and explore some of the different disorders that result from endocrine malfunction.